Right, finally, we've got Orla, who's going to talk about my favourite weird metal.
Yes, indeed. Good morning, everyone. Is that showing? There we are. Great. Hi, I'm Orla Macdonald. I'm a pharmacist at Oxford Health NHS Trust. I'm a mental health pharmacist, and I've been working with the Bennett team since 2018. And we did a project using OpenPrescribing hospitals and OpenPrescribing on lithium. Now, why are we interested in lithium? Lithium is a fascinating drug, especially if you're a psychiatric pharmacist. It has been used in psychiatry for over 100 years, and we don't still know quite what it's doing in the brain. We don't know why it works. But what we do know is that it does work. And in fact, it is the drug of choice in every national guideline for bipolar disorder written in the last 10 years. So we had our NICE guidance, we had our BAP bipolar guidance, the Canadian guidance, the New Zealand and Australian guidance. They all say use lithium first for prevention of relapse in bipolar disorder. But of course, it's an old drug. And over the last 30 years, we have seen newer drugs come on the market to treat bipolar disorders. So antipsychotics, different forms of valproate, etc., etc. And so about 10 years ago, there were several, well, this was published in 2019, but what it was showing was a trend of lithium prescribing going down. And indeed, a trend of the antipsychotics and the anti-seizure drugs and every other type of drug going up in the treatment of bipolar disorder. Now, since these guys gathered that data, what has happened is there have been a load of comparator studies come on. So RCTs, a huge meta-analysis of RCTs looking at the comparators in the treatment of bipolar disorder, huge systematic review of real-world studies, all of which said lithium is the most effective drug at preventing relapse. All these other new drugs are not as effective as lithium, and what that has led to, if you look at over the last 5-10 years, is a lot of editorials, a lot of reviews saying, should we be using lithium more? And so that was the question we wanted to ask. Has there been a change in the trend of lithium use in the UK in the last 10 years? Now, of course, if we just wanted to look at primary care data, we could have done this 10 years ago because we'd had OpenPrescribing available to us then. But lithium is an unusual drug in that it is shared with secondary care. It has to be started in secondary care and it's handed over to primary care prescribers with a shared care agreement. And certainly it is possible that in some areas they're holding on to that prescribing within secondary care, lithium clinics, etc. So we couldn't really tell the story about lithium until we had access to the secondary care data. Now, you've heard earlier on today about what these data sets are. The English prescribing data set is what OpenPrescribing primary care data comes out of. We've got the secondary care medicines data set, which is RxInfo providing that. And then we also looked at hospital FP10 data. So that's if I'm a specialist prescriber writing on a prescription in a hospital, but you take it to a community, we included that data as well. So this is pretty much all of the lithium prescribing in England over the last 10 years. The other slightly unusual thing about lithium, when you're doing data collection like this, we were looking at quantity, we want to know how much lithium is prescribed, but if you measure lithium in terms of milligrams, that doesn't clinically make sense because the products aren't bioequivalent. So we converted everything into millimoles and, as was recommended, chose the defined daily dose. So about 24, the World Health Organization says 24 millimoles is the DDD for lithium. So we divided all our quantities by 24 and we said, okay, how many defined daily doses of lithium have been used across in all these different sectors? Now, we haven't published this data as yet. This is your first look at, but we are hoping to publish this in time. And sure enough, what we see is that lithium prescribing has continued to decline despite all of those national guidance, despite all of that, those editorials and evidence. It is still on the decline. The other key piece of information that we got from this data is that it is primarily dispensed in primary care. The vast majority of lithium is coming out of primary care, so using OpenPrescribing on its own wouldn't necessarily have been a bad thing. What is interesting, though, is that in secondary care, we're seeing a slight increase over the last couple of years. We're seeing those lithium numbers go up, those DGDs numbers go up. Now, I would say that is very much against the trend of the 10-year plan that's saying let's move care from hospital to the community. Bipolar disorder is a long-term illness. You want to be getting your lithium, your treatments from your local GPs. So this is an unusual trend. We were also really keen to see, was there any regional variation? Is there any areas that have really championed lithium? They're doing well on their lithium prescribing. For the most part, what we found was the trend continued to decrease. Now, the reason we've only gone from 2019 in our regional data is that we only had all source data from 2019. We had the OpenPrescribing, the primary care data from before that, but all sources from 2019. And most regions are showing a decrease, except for London. London is bucking that trend. What's London doing around lithium prescribing that we don't fully understand? But one of the things London seems to be doing is giving it more out of its hospitals and its specialist centres than other areas. Why is that? We need to look at that more, and it's the data that's allowing us to ask the right questions, because we do need to ask the question as to why we're not using lithium. But by looking at the data, we can really think, well, what's happening in London? What is happening with those systems that perhaps we could learn from and improve lithium prescribing there? So, like I say, we were able, using our wonderful data systems, to really show that London is actually 3 times as much lithium comes out of London secondary care than in other areas of the country. And we were also able to show that up in the north, you have a lot of specialists writing prescriptions for lithium that's going out and being dispensed in community hospitals. So again, unusual systems up there being allowed to provide lithium, and these will all allow us to investigate this further. So our key findings really is that lithium use is still declining, but primarily it is being given out of primary care, and that's a real positive for people with long-term conditions. They want to go to their GPs to get it. We are seeing some variation, regional variation in how people get access to lithium, but we're not seeing any major champions across the country for providers of lithium. And I think this is, I will leave you with this thought. There was a study done in Sweden several years ago where they did have significant regional variations in, and a very similar study, big data study, similar regional variations in how lithium was being provided across that country. And what Martin Skold and his team managed to show was in the areas where there were low amounts of lithium, there were higher rates of relapse of bipolar disorder. So it was an association, but it was a really important one to take home. It's a very important paper. So I think it's really important for us to make sure we don't have significant areas of regional disparity, but also we need to think about how we can improve lithium access. There are limitations with any kind of study like this. We've talked earlier about how you think about this kind of data. Obviously, it's great that we've huge amounts of data. We've pretty much, we think, captured all of the lithium prescribing and use in the country. But we do not know who these people are. We don't know who the patients are, and we don't know what their diagnosis was. Now, lithium primarily is used for mood disorders. That is its major function. However, there is a niche use of lithium in cluster headaches, which is a tertiary, it's kind of third line and possibly more secondary care. So maybe that explains some of the increase in prescribing in secondary care. We've also we've compared it against general population estimates, but again, when you're doing big data like this, maybe it would be more accurate if we compared it against populations of people with bipolar disorder, and we haven't considered that. That's work we could do later. But apart from that, yeah, there are the limitations that we always have to keep in mind. That's it. Thank you. Anybody?